So I want to emphasize here that our consideration this week is not of healthcare itself, but of press coverage of healthcare. I'm going to just enumerate what I think are some of the major issues in healthcare and its coverage that you should keep an eye out for, but they should also feel free to amplify if there are concerns of your own. Put simply, if you think about healthcare, I think the basic question is there a fundamental right? Is there a fundamental right for all people to have access to good health care? Many societies say yes, that's true, and the governments provide a national health care system. Two of the more familiar places that this comes up are Great Britain and Canada. The United States, to date, has said no. It is not a right that everyone is entitled to. And as of now, the only people for whom the government of the United States provides health care is members of Congress, members of the military, and veterans of the armed forces, the disabled, the elderly, and many, but far from all, of the poor. In the end, I think this question I'm asking about are people entitled to health care really it's a financial question for many societies, it's an ethical question for many people, and it's also a practical question, because in the end what it comes down to is who pays or should pay for health care for people. Should people pay their own way? Well, where does that leave everybody who can't afford it? Should the taxpayers pick up the tab? I mean, isn't that one of the essential functions of government? Some people say yes, some people say no. And as you're probably aware, whatever your degree of interest, the Affordable Care Act, which is known or referred to as Obamacare, was very difficult for the government to pass, and since then has been challenged frequently. You may recall, I mean, this was like a major moment in the news a few years ago when the Republicans were trying to undo Medicare, and it was a very close vote. And Senator John McCain from Arizona, who was dying of brain cancer, came onto the floor of the House, very visibly ill, and voted with the Democrats to retain the Affordable Care Act, something for which the president and many parts of the Republican leadership never forgave him. This is particularly timely today, as I said in my email, because this very day, Tuesday, November 10th, the latest challenge to Obamacare came before the Supreme Court, which heard the case this morning. I hope some of you had time to listen. This is a relatively new development that Supreme Court hearings are broadcast, not yet on television, but on radio and streamed on the web. And I found it fascinating just to hear the questions from the different justices and some of the answers and some of the discussion and debate. And I think it's too soon to say what the upshot is. The ruling probably won't come for months, but the legal analysts who were following the case and who wrote about it about an hour and a half after the hearing ended seemed to think that the court would uphold Obamacare. And both Justices Roberts, the Chief Justice, and Justice Kavanaugh both basically said that they were in favor of the law, and that even if a particular provision is severed from the rest of the law could be upheld. So that's this morning's news, and there'll be plenty of it on the web today, and might well be the lead story in tomorrow's newspapers, unless something dramatic happens on the political side. One of the there are a couple of unusual aspects of healthcare in the United States that I wanted to call your attention to. One is that while some of the best research, uh, best medical equipment, best doctors, best procedures are developed and practiced in the United States, there are also some areas where the outcomes are quite dreadful. And one of the most startling statistics is the infant mortality rate, where among all the nations of the world, the U.S. has the 18th worst rate, far worse than any country in Europe or countries in Asia. And, why does such a wealthy country with the largest GDP in the world and such an advanced healthcare system tolerate this? It just seems to me, as a human being, but also as a journalist, that if more people thought about things like this, there would be an outcry and a demand to do something about it. Another very unusual aspect of healthcare in the United States is that most health insurance is tied to employment. That is, health insurance plans or a choice of plans are provided by employers rather than the government. And this arose largely in the aftermath of World War II, when unions were strong and workers were bargaining for higher and higher wages. And some companies at the time said, well, rather than simply giving you money, we'll put health insurance on the table. And that remains the practice and works well, reasonably well, for this steadily employed. But the important concept to hold on to here is health insurance, because it's attached to your employer, is not portable. So when you change jobs, or if you lose your job, you're no longer eligible for that health insurance. And if you change jobs, you need to switch insurers. Not all insurers offer identical coverage. Some of them operate only in certain states, but not others. So it's, I don't want to say it's a peculiar arrangement, but it's a very unusual arrangement and very rare in this modern world. It also leaves out a very large portion of the workforce. Short-term employment, seasonal workers, many part-time workers do not qualify for these company-provided benefits. Nor do freelancers, freelance writers or journalists, or any independent contractor. There's a case, a series of cases that was very much in the news in the run-up to Election Day, where California, like some European nations, has been trying to require that drivers for Uber and Lyft be treated as employees rather than freelancers. And if they were treated as employees, they'd be entitled to health insurance, paid vacation, limits on working hours, things like that. And there was a lot of resistance to this, and California put it to a referendum of all voters, and it was on the ballot on Election Day, and the referendum lost. So, in other words, the companies, Uber and Lyft, and their point of view prevailed, and drivers there will continue to be treated as independent contractors without any benefits. So this is something that's been very much in the news, sort of driven mostly by the growth of Uber and Lyft and other competing services. Is a very big issue in many of the nations in Europe and in Asia, where these services are equally possible. Excuse me a second. And, for those of us in the craft of journalism, losing a job or deciding to freelance and go on your own means that you are responsible for your own health care insurance, which can be incredibly expensive. So this is, one of the major issues in healthcare in the United States. But the issue of insurance aside, and all the oddities associated with it, and there's a great deal written about premiums, the cost of premiums, co-pays, which are the fee you pay when most of the cost is covered by insurance. And just to give you an example, through City University, I and my family participated in a Blue Shield program, Empire Blue Shield, and the copay is $15 a doctor's visit. So in other words, if we go to any doctor who participates in the network, we pay $15 and the insurance picks up the rest. If we see a doctor outside of the network, the Blue Shield network for this particular plan, we have no coverage at all. So it's very expensive and we try to minimize that. But the issue of insurance aside, there are several major issues in healthcare that I think the press does a pretty good job of focusing on, but I want you to be aware of. And one of them is access. Who has access to healthcare? How good is that access? How many choices do you have? We've seen a lot about this in the news in the context of abortion and abortion restrictions, and how in a couple of states now, I think Louisiana is one, there's only one clinic in the entire state that provides abortion services. So access is severely limited, even within the context of the law. There have been a lot of studies, and really this has sort of come to a head during the pandemic, about the huge disparity in healthcare between the wealthy, the well-off and comfortable, the working class, and the poor. And you can see huge gaps in the availability of coverage, the number of doctors, the number of hospitals, before you even get to the issue of quality. But so access is one really good area for journalists to cover. A second is outcomes, which basically means, when you go to a doctor and the doctor suggests or orders a treatment, how effective is it? Or if you're in the hospital, do you emerge better for the experience or not? And the answers are not as simple as you think. And there is just an enormous wealth of data available from the government and from nonprofits that study healthcare that look at statistics both for individual doctors' practices and hospital records. And you can find, if you need, say, heart surgery, you could look at the hospitals in your area and see what their records were on outcomes of different treatments. That doesn't mean you always have a choice, because if you do have health insurance, some of the hospitals might participate in your insurance plan and some may not. But this is something to look at, and there are different ways that you can measure the quality of care as a way of thinking about outcomes. One is that you can find codes of best practices that different organizations and different specialties in medicine create and disseminate, and you can analyze how well a given hospital follows those procedures. This is largely data-driven coverage, because it can be very hard to get people in the hospital, particularly employees, but also patients, to talk to you. And these are very personal issues, so people may not want to discuss them anyway. So measuring against a suggested standard of care is one good metric. Another thing that you can do through Medicare, which is a government agency and which keeps formidable records, you can analyze data, particularly billing data, to assess complications and the number of deaths. For example, how many people who go into the hospital with pneumonia die, and how many emerge safely. How many who have a knee replacement or a heart replacement run into complications. One small piece of this is readmissions. If you go to a hospital, you have a procedure, or you're treated for something, and then you're released, and then a short time later you have to be readmitted. All of that data is available, and with very little training, you can do some very good healthcare reporting. And there are organizations like an Association of Healthcare Reporters that have a lot of how-to guides and a lot of training. And this is an area where I think it's likely to assume that the number of journalism jobs will continue to grow, because this is such a broad and very deep issue. Another measure you can do of quality of care is to compare different regions and try to come up with data that demonstrates, which states and which parts of states are better than others. This can be, very good for reporting on broad healthcare conditions, and can be very good for doing individual stories about choices that families have to make. And one data map, sorry, just squiggling around here trying to get comfortable. One data map that I put in the Blackboard folder for this week shows infant mortality rates by state. And one of the things you will see is that the states with the worst records are in the southern United States, with one exception, and that was Ohio. Oh, and also West Virginia. Both of them had a relatively high number of infant mortality rates, while the Northeast, the Mid-Atlantic states, New York, New Jersey, Pennsylvania, the West Coast, all had much better rates. So that's not so much consumer reporting, but it is, an interesting look at equality under the law, equality in healthcare, and I think, it's a constant area where good journalism is both welcome and actually does some good. It's harder sometimes to report on variations among specific doctors. You often see magazine covers about the 50 best doctors in New York, or the 50 best orthopedists in Manhattan, and they're sort of bogus. I mean, they're usually advertiser driven, and it's just based on peer review, or not even peer review, but peer knowledge. So if you have a reputation as being a great orthopedist, doctors who don't know you may mention it. But if you're a wonderful orthopedist who doesn't have a high public profile, you wouldn't show up in these rankings. So those can be taken with a grain of salt. What you can look up, and what is a matter of public record, are complaints filed against doctors, the outcomes of those complaints, lawsuits filed, resolution of those lawsuits, and financial judgments. And you see stories from time to time about doctors, sometimes well-known doctors, who have frequently settled cases or been found guilty of some breach of medical ethics or bad practices. So very fertile ground. You cannot underestimate the scope and the scale of healthcare, and as a result of that, of the healthcare coverage that's needed. In the United States, healthcare consumes 17% of gross domestic product. That's a remarkably high number, higher than any country in Europe, any other developed country. And what this reflects is maybe to some extent the availability of healthcare, but another thing that it reflects that comes up frequently is the ever-growing cost of healthcare. And healthcare in the United States is very expensive. The cost keeps going up. This is particularly true of medicines, and many public figures and elected officials, ranging from Bernie Sanders and Elizabeth Warren, maybe on one side of the political spectrum, and Donald Trump on the other side, all of them have called for limits on drug prices, lower drug prices. They've wondered why are pharmaceuticals so much cheaper in Canada. It's a well-known fact, an established fact, that many Americans drive, well, this is before the pandemic, but would drive into Canada simply to buy their medicine because it was so much cheaper. And why is that the case? The answer is that in countries that have a national health service, that service negotiates with drug makers for reasonable prices. And because they represent the entire market in Canada, the entire population, they have a lot of leverage in establishing the prices. In the United States, that's called the single payer concept, where there is one payer for all medicines, and that's the government through its insurance program. That is not the case in the United States. And in fact, Congress has specifically passed legislation outlawing, or not outlawing, but just making illegal any attempts by the government to try to be a single payer and to negotiate lower drug prices. So even if you are well intentioned in wanting to do this, as I think Donald Trump was, you find you don't have a lot of leverage. And drug companies are quite adamant that they need to protect their profits, that they have a legal obligation to their shareholders to maximize profits. That's true. And they also say, and a constant theme in coverage of this issue, is that the high prices are needed because so much of the money collected goes into medical research and pharmaceutical research, and that gives them the incentive to come up with new and remarkable drugs. But this is an issue that isn't going away. There are people on limited income, people with pensions or Social Security, who find that they're paying a growing portion of their limited income for their medications. And in many cases, we know this, and I think journalists have done a very good job of documenting this story. People stop taking drugs that they need because they can't afford them, or if you have a drug and you're supposed to take it every day, they maybe take it only every other day because that's all they can afford. And it's a terrible situation to be in, where for you or your family, you have to make a decision, should I buy food or should I buy medicine? I can't afford to buy both. And I think it's one measure of a country that does so many things so well that it has never really chosen to address this head on. And I think the pressure to do so will continue, but where it will lead, I don't know. The bottom line here is that the big corporate players in healthcare and medicine are stronger than the public. They make enormous financial campaign contributions. They hire lobbyists. It's not just healthcare. I mean, this is corporate life and in many parts of the world. But it's particularly pronounced in healthcare, where they have been able again and again to beat off significant reforms that would lower prices or increase competition in markets. So this is something that is a continuing story. I think it will probably last for the rest of your lifetimes. I think another very good issue in healthcare that has generated much good coverage, but there's always room for more, is how does the healthcare system, or how do governments, local, state, federal, respond to epidemics? This was a big story long before the current pandemic. Excuse me. As you probably know, and has been very well documented, there has been an opioid epidemic in this country for years. There are thousands and thousands, tens of thousands of suits being brought against drug manufacturers, regulators who failed to curtail things, doctors who overly prescribed. And that's a story that has national ramifications, and you can look, step back and look at national data, but it's something where you can also bore in on one community, one small town, one neighborhood in a town, and find data about that and tell that story in your neighborhood. And that's something that journalists have done very well. There's also, and has been for quite a few years, an epidemic of obesity in this country. It seems the data shows that it is more prevalent among the poor, because good food often costs more than less healthy food. So it's a story with racial overtones, it's a story with class and economic overtones, um, but it can give rise to many, many good stories, from um, attempts to have people eat healthier to the whole debate about organic food and factory farming, something that we'll take up in much more detail in a couple of weeks. Um, I mean, you could ask a question. You take an organization like the Girl Scouts, which is a fairly benign organization with a good reputation, and their major form of revenue every year is the sale of Girl Scout cookies. So if you have a nation where obesity is a known problem, why do you have this good-natured civic organization selling unhealthy cookies in such volume? And it's not just children who eat them. It's typical, in many homes to, when the Girl Scouts come around, to stock up on cookies. I know when years ago, when my daughter was a Girl Scout and my wife was a leader at one point, and I was working at the New York Times, I used to bring my daughter to work and to take cookie orders. And we did this for a couple of years, and there was one year where she sold 230 boxes of cookies. And then it was my problem to have to deliver them. I had to get a hand truck, and but I certainly didn't give a thought to then. I was then to the health issue, or how we were, to put it, bluntly, contributing to bad eating habits. So that's just like one small piece of the story, but something that I think can lend itself to very good stories. Is obesity acknowledged? To what extent is it associated with bad food? To what extent is it associated with too much drinking, lack of exercise? The U.S. certainly is not the only nation where this is a problem, but many, many good stories there. And then, of course, we come to the pandemic, and I don't really have a lot to say about that, and I haven't recommended any readings about it because I think you're surrounded by it every day. And you could say, I only have 2 hours a day to read news. And for some of you, I think that would be generous because your lives are so busy. You could spend that whole 2 hours every day reading pandemic news, how it's playing out in different regions, how the government is responding or not responding, what are the best options for care, how is the development of medication going. We just had some very exciting news over the weekend that Pfizer has been getting very good test results on its vaccine, and there will be a rush to manufacture it, and then once you've manufactured in volume, how to distribute it, and how do you distribute it nationwide, and who gets it first. And I think there's a general consensus in most countries that healthcare workers should get it first because they're the most exposed and most vulnerable. But just associated with that, there's so many stories that people really need to hear. So I think that healthcare has grown into one of the most important beats in journalism. And there's so many different levels to it, from what consumers need to know when shopping for a doctor or considering different medicines or considering a healthy diet, up to medical research and drug development and medical machinery. Medical technology, has become remarkable. And this plays out through many different areas of healthcare, which you may or may not have thought about, like dental care. It used to be, well, I guess it was decades ago at this point, but you would go to the dentist. The dentist would, once a year, wedge little pieces of film into your mouth and then put an x-ray gun up against the side of your head and take x-rays of your teeth. And that was how they decided what was healthy and what work you needed. And then as the technology changed, they discovered, first of all, how to do this digitally, where that you no longer have to put film in your mouth. You can just put a probe in your mouth, and the camera emits a much smaller dose of radiation, so it's much cheaper and much safer. And then you also wind up with images that, because they're digital, you can take them home on a disc and bring them to another dentist. They can be emailed to specialists and so on. So there have been remarkable changes there. And the same is true, I mean, this doesn't get as much attention, but in veterinary medicine. And there's a very large range of veterinary medicine. There's, a branch of it that deals with exotic animals and zoo animals. And then there's an area that deals with farm animals and working animals. And then, of course, there's the pet industry. And much of the same technology that's available to humans is now available on a veterinary level too. MRIs, joint replacement, things like that. But they're incredibly expensive as well. And so some people have pet insurance, and some people do not. And some animals receive wonderful care, and many do not. And maybe that's not on the same level of human care, but for many people it is. And of course, if you're earning a living and supporting your family through working animals, as on a farm, it's a really important issue. Of course, if you regard your pets as family members, as we do, then their care is an issue you need to think about too. And what is sensible, what is affordable. So there's just a huge array of stories out there waiting for you to look into and tell. And for most of them, you don't need specialized training. You just need curiosity and a willingness to read and to ask tough questions. I think there's some excellent healthcare coverage in the United States that's broad, that's deep. And there are many news organizations that do that very well and have teams of healthcare reporters. So I put in the folder a few things I'd like you to read, but I just assume that in the course of this week, you will see yourself surrounded by news about healthcare, and I hope you digest a lot of it. Any questions, please let me know, and otherwise I will be back next week. Thank you.